All right, good deal. All right, cool deal. So look, just get in tonight. Please remember, don't worry about the chapters. Just match the chapter name. Because again, there's some discrepancies between JB learning and then what we will go through on the chapter. But your questions and everything have been matched up. So I just didn't feel like matching the chapter numbers and all that. That's the story behind it. So dive off in tonight. It is pretty lengthy, but we're gonna make sure we get all the stuff we can get out of it and move forward. So going over airway management. This out of my way. Sorry, there's stuff everywhere. I just got to get it situated. All right, so we're going over airway management tonight. It applies the fundamental knowledge of anatomy and physiology to a patient assessment and management in order to assure the patient's airway adequate medical and ventilation and respiratory of patients of all ages. Let me get through these and then I'll break it down to y'all a little bit easier. So we're going to go over airway anatomy, how do you assess it, and the techniques of assuring the patient. And then anatomy of the respirations, we'll talk about physiology and pathophysiology of respirations. With pulmonary ventilation, oxygenation, respiration, we'll talk about external, internal, and cellular respiration. Assessment and management of adequate and inadequate respiration, basically what is good for the body and what's not going to be so good. We want, what ventilations is going to be supportive for life. And then talk about supplemental oxygen therapy. What can we do to help them? We'll go over assessment and management of adequate and inadequate ventilations, artificial ventilations, minute ventilations, alveolar ventilation, and effective artificial ventilations on cardiac output. That's a lot. I mean, I know it sounds like a lot, and we're going to keep going. So we talked about this before. So the pathophysiology applies the fundamental knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. All right, so finally now we're going to start getting really what we care about. We don't really want to listen to all the stuff we're going to go over again. So, and the single most important step in caring for patients to address life threats, which that's what we've built up to. We started to the beginning phase. We talked about things. Now we're building up to what is more. It's going to help us build our patient assessments. And it's threats components to step to ensure that they can breathe adequate, which again, we all want to make sure that we're breathing. That's very important. When the ability to breathe is disrupted, oxygen delivery to the tissues and cells is compromised. Oxygen reaches the body, tissues, and cells through two separate but related processes. You have breathing and circulation. All right, so here's the process. Let me get over here on the big screen. So this is the upper airway. We've talked about this before. We know the pieces and parts of the airway, the certain parts of the anatomy. So we're going to breathe in through the nose or through the mouth. It's going to go down to the right and left lung. Now remember, we have which side has 3 lobes and which side has 2 lobes? Do I remember? What
right
lung?
side has 3 lobes.
Perfect. Good deal. Appreciate it. All right. So then the oxygen is going to come in. It's going to inflate both lungs. The diaphragm is going to contract. And when it contracts, it helps us breathe. Remember, this is something that's stuck in my head forever. L3, 4, and 5. If there's ever any type of lumbar spinal cord injuries and it affects L3, 4, and 5, those are the ones that keep the diaphragm alive. So when you start having issues, they talk about lumbar issues. If they start having talks about L3 and 4, you could potentially have some breathing you should have some breathing issues. You could be put on like CPAP on a normal regulated time. You'll have regulated oxygen. So, all right, back to normal parts here. So we're going to break it down into the lungs, and we talked about going down into the alveoli, then we go into the pulmonary capillaries. So again, we broke this down before between the upper and the lower airway. So we just remember where it divides at. I don't know why this starts every time using too much oxygen. So we talk about those. We know that the process is there on the upper and lower airway. Just I want to reiterate that because that's going to be important the further we move on. All right, so the anatomy of the respiratory system. So the respiratory system consists of all structures that make up the airway and help us to breathe or ventilate. The airway is divided into upper and lower. And remember, this is an automatic system that we don't have to do, that the body automatically generates us, be like, all right, Chris, breathe, Chris, exhale, Chris, breathe in, Chris, breathe out. So those are an automatic, it's a non-regulated process, because some of us, and I say some of us, can't walk and talk and chew at the same time. So you can imagine trying to get all these functionalities, things of everything going on, and you're like, oh, I got to breathe in there somewhere too. So that's the reason why it's just cool to know that the body does that. All right, again, come up the upper airway. We have the nose, the mouth, the oral cavity, the pharynx, and the larynx. Then we talk about the main functions of the upper airway is to warm, filter, and humidify air as it enters the body. So remember, that is what your nasal hairs are for. So it filters the air, it helps warm it, it gets to the moisture as it goes down into the airway system. I'm sorry. I guess I should be back at work. I have a reason to be tired. So we talk about here is the muscular tube extends from the nose to the mouth to the level of the esophagus and trachea. And it's composed from the top to the bottom in the narrow pharynx, oropharynx, and to the laryngopharynx. Here's a breakdown of it. Let's get that talked about here. So this is coming down from the nasopharynx, going into the oropharynx, and this is cutting down into the lungs to the laryngopharynx down here. We'll go break off into your right and left main stem. This is right in here to where your Adam's apple is, men. There's your spot that you can push on. So to look at it this way, so this is the basilar part of the skull. If I'm going to intubate somebody and I open up, this is the top part of their mouth, okay? So when I go to insert the tube into the mouth, as I'm coming in this way, this part right here, your uvula, is what I'm looking at, okay? We know that. Well, then you go down a little bit further and you will, if you get the right angle, you have to push in and up. And I can see this part right here with my eyes. I don't really have to have any type of tool to see that. And that's where the tube gets inserted all the way down into here. It comes out into your lungs, your right and left. You can come look, my wife. So my wife is interested in what I was talking about. So, and that's how when we go to intubate, that's what you look for. Now, they don't break it down like this, but we look for that V, and that's what we aim for when we go to intubate. So we have these cool toys that are out there now. They have the laryngoscopes with cameras on there, so I can be looking at it like this, trying to intubate as I'm looking at the camera, and I visualize my tube passing through the cords. That's just another visual confirmation. And then you have condensation on the tube. So those are just different things. It's not really like it matters to you guys, but I just wanted you to understand what their paramedics are really aiming for when they go to tube somebody. So the oropharynx is the posterior portion of the oral cavity. Just to show you a better picture so it breaks it down a little bit better. The esophagus is superior to the larynx, and this helps prevent food and liquid from entering the larynx during swallowing. So looking at this, now you understand. So here's your uvula, your tongue, and your teeth and your gums. Breaks it down to the nasal cavities. So as we talked about this before, if I go to COVID test you, we want it to go is in a PCR form. You want it to hit back in here. Now, yes, that's hard, but this is the uvula that blocks the air and the fluids from getting off into the respiratory system. So your esophagus, your oropharynx, and all these different parts is what we just showed on another slide. But this just shows you a portion, a side lateral portion of the skull and the muscles and all that stuff that hopefully we get it a little bit better. So remember, this is the strongest muscle in your body right here is your tongue. We use that on average more than any other time, any other muscle in the body. We use that for a lot of things. And that's what makes it the strongest muscle in the body. Okay, let's see here. All right, so the larynx. So let's talk about this part. So just imagine this is right here. This is what I'm looking at. So your your Adam's apple is going to be right here. As you can see here, it's labeled right there. Ladies, you're not going to necessarily feel that, but a little bit lower in your cricoid membrane, you can feel that. If you'll So if you have a man that's in the house and he's standing around looking, trying to figure out, bring him over and then feel. So if you'll feel their Adam's apple, you'll go one finger below and slide down just a little bit, and you'll feel a really soft area right underneath the Adam's apple, about 1 finger's distance. And that is where we're talking about right here in the cricoid membrane. You can feel the cricoid cartilage as you get them to look up. You can start to feel in all that different anatomy, but those are just airway marks. Those are marks that we try to memorize. Those are just landmarks that help us know what's going on. Now, we're not going to see any of this because that's your tongue. We're not really going to see any of the trachea and all that because, yeah, we can grab sides of it as we go in here, and we can feel sides of our trachea, but you're really not going to see those landmarks unless it is a very traumatic situation, and most likely that person is not going to be alive to tell you what's going on. But these are some of the things and the landmarks that we're going to see here. Just tidbits there. So the cricoid cartilage forms a V-shaped anteriorly, which is the Adam's apple. The cricoid cartilage is the cricoid ring, is the first ring of the trachea. And then the cricoid membrane is the elastic tissue that connects the thyroid superiorly to the cricoid ring inferiorly. That's a tongue twister. So the glottis open is the area between the vocal cords. It's the narrowest part of the adult's airway. That might be a pretty little question there. Let me read that to you again. So the glottis, which is right here on your screen. So the glottis is the opening in the airway between the vocal cords. That is also the narrowest part of the adult airway. So the vocal cords are white bands of thin muscle tissues, and they're partly separated at rest, which helps produce speech and sound. Protects the trachea from the entry of substance like water and vomit. So if we'll look at this picture, this right in here is where we're going to start looking at our vocal cords. This kind of makes up the same color as it goes further down. It does that part there. All right, so what's this say? The anatomy of the lower airways, the function of the lower airways is to deliver oxygen to the alveoli. So once it gets past our upper and lower or upper airway, now we need it to get into our respiratory system and start pushing out oxygen to the alveoli. So we're gonna start breaking it down a little bit further. So elements of the lower airway. So it's the trachea. So let's talk about the trachea the most. So that is a conduit for airway entry into the lungs. It begins directly below the cricoid cartilage, and it descends anteriorly down the middle of the neck into the thoracic cavity. In the thoracic cavity, the trachea divides at the cornea and into main stems, bronchi, right and left, which is what we've talked about, goes the right lung to the left lung. The bronchia are supported by cartilage. They distribute oxygen to the lungs. And on entering the lungs, each bronchus divides into even smaller bronchi, which divides into bronchioles. So let's see if we can flutter some memory there. Which, when it breaks down from the right to the left main stems, which one is shorter? Is the right one or the left one a little bit shorter? And I mean shorter as in like higher. So when it splits off right here, is the right one a little bit higher or is the left one a little bit higher? Does anybody remember?
Right one.
You're right one, that is correct. So here's some information to you. So if you're ever helping your paramedic and they intubate and they're like, all right, listen for the lung sounds, and they start using your bag valve mask and they start pushing breaths. Well, you only hear it on the right side, but you don't hear it on the left side. It's because they have a right main stem intubation. So if they were to back it out a little bit, you're going to hear breath sounds on the both left and right. So it is very common to have right main stem intubations because they may have pushed it too far in, and it's not like it's something that's bad. It's just sits a little bit higher in the thoracic cavity. But at the same time, as we need equal oxygenation, so that's why we need both right and left lungs to inflate and deflate. So just a little tidbit information there. Sorry, Wally's, tidbit information that's not important. So here's a figure on the slide. So there's the trachea and the lungs so it doesn't show it here, but most of the time like you said, your right side's a lot higher. And I mean, maybe like a couple of centimeters. And then it breaks off into the alveoli, the main bronchiole. We talked about smaller bronchiole. And then we know as we've got down here, y'all have seen it or you go down into your bronchioles, gets down into the smaller portions of the lungs. So you talk about here, and where it divides to the right to left is your cornea, and that is the division area. And then you talk about your windpipe here. So if you notice, it's about even with the collarbones. You go to a little bit higher. That's into your trachea. You see the 3 lobes and the 2 lobes, like we talked about a minute ago. All right, so the bronchioles are made of smooth muscles. They dilate and constrict as oxygen passes through them. So the smaller bronchioles connect to the alveoli, and it's the site of oxygen and carbon dioxide exchange. So the carbon dioxide and oxygen exchanges at the alveoli level. So millions of thin-walled balloon-like sacs, their alveoli are surrounded by blood vessels, which are pulmonary capillaries, and oxygen diffuses across the alveolar membrane into the pulmonary capillaries. Oxygen in the pulmonary capillaries is transported back to the heart and distributed to the rest of the body. The carbon dioxide diffuses from the pulmonary capillaries into the alveoli, where it is exhaled and removed from the body. I'm not sure if this tells you, but I will go, and I hope you all already know this. How much oxygen is in the air at any given time? Does anybody know? I heard something, but I don't know what it was. Dominique, did you say something?
I said 21%.
Yes, okay. I thought so. It sounded like some robots were in my ear, so I was making sure. All right, so that's correct. Nathan, you're right too. It's 21% of oxygen that's out there all the time. Now, how much oxygen does the body use out of that 21%? Does anybody know? So good guess, but we use, let me type that in here. So I will type it down there. So we use 16% of the oxygen that we take out of the 21. So there's 5% of oxygen that we exhale right back out into the environment. So out of the 21%, the body uses 16%. Just another tidbit information that kind of help you out later down the road. All right, so the heart and great vessels of the vena cava and the aorta are also present in the thoracic cavity, and they're very important for respiration. So remember, when we went over some other chapters where the oxygen rich blood goes down one side and the deoxygenated blood comes back to the heart. So it's got to go down as it oxygenated all the way down into our toes. And then as it's forming, now this is not in a one breath situation, as y'all know, but this is a continuous process. It's going and pumping in a circle. So just don't forget which side takes the oxygenated versus the deoxygenated. So as you can see over here, as the diaphragm contracts, the lungs, air comes in. So it opens up the thoracic cavity. As you can see, is the pressure is the problem. So it creates that negative pressure, and that's where we're able to get the negative pressure where the air rushes in. Sorry, I got sidetracked. All right, so the mediastinum is the area between the lungs, which contains the heart, I would write this down if I was y'all. So the mediastinum, and this is the area between the lungs, contains the heart, the great vessels, the esophagus, trachea, major bronchi, and many nerves. The pharynx nerve is also found in the thorax. Also, let me start it over. The pharynx nerve is found in the thorax, and this allows the diaphragm to contract, which is necessary for breathing to occur. So I'm gonna let that sit there for a minute so y'all can write that down. Write those 6 down, we'll be good to go. Has everybody got it? Somebody give me a thumbs up if y'all are good. All right, so going right along. So the physiologically, that word's got me. So the respiratory and the cardiovascular system works together. So it ensures that the constant supply of oxygen and nutrients is delivered to all of the cells of the body. It removes carbon dioxide and waste produced from the cell. So when we breathe in, our heart is making sure that we turn around and pass that same oxygen through our entire body. So not only it's running tandem, the heart and the lungs are running tandem with each other. One is to create the negative pressure, brings in oxygenated, and when it creates that positive pressure, we're going to breathe it out. We're going to exhale. So what it's allowing us to do is the heart and the lungs are back and forth working to making sure that we get oxygenated blood, because that's what we need, and that good the good oxygen is pushed throughout, and then the bad oxygen is brought back and we exhale it. We turn around and get rid of the waste, can go into the cellular level and be dumped out into urine, feces, and other parts like that. So that's how we get rid of things. That's just the normal process. So if you look here on table 11-1, it's the ventilation and oxygenation respiration. So ventilation is the physical act of moving air into and out of the lungs. Oxygenation is the process of loading oxygen molecules onto hemoglobin molecules at the bloodstream. The respiration is the actual exchange of oxygen and carbon dioxide in the alveoli, as well as the tissues of the body. I would hope that y'all mark that in your book to go back over, because that's important. They're probably, I would say, if they asked that, they would try to say which is the most correct. Or that's for registry, and I do not allow on our test. I don't allow matching. I don't like that. I just don't like that type of questions. But it may ask you what is the process of loading oxygen molecules onto the hemoglobin, and then you have to choose the oxygen, and they'll give you oxygenation, ventilation, respiration, and some off the wall topic to try to throw you off there. So mark that in your book. That's probably something to go back over a couple of times. So the processes involved are ventilation, oxygenation, and respiration. So the ventilation, that's the physical act of moving air into and out of the lungs, which is necessary for oxygenation and respiration to occur. The active muscular part of breathing, the diaphragm, so inhalation is the active part of breathing, and the diaphragm and intercostal muscles contract during inhalation, creating a negative pressure within the thorax, which is allowing air to enter the body and travel into the lungs. So remember we talked about the negative pressure. When we we'll open up and creates all that negative pressure for air to rush in. Be a picture coming up in just a second. So the lungs require the movement of the chest supporting structures to expand and contract during inhalation and exhalation. Partial pressures. So this is where it gets funny, like when we talk about minute volume, tidal volume, those were, when in the beginning you were like, I don't really know what you mean by that, but sure. So the partial pressure of oxygen in the alveoli is 104 millimeters of mercury. The partial pressure of carbon dioxide in the alveoli is 40 millimeters of mercury. The deoxygenated arterial blood from the heart has a partial pressure of oxygen. Here, let me see if I can copy this, put this down, because that is probably important for y'all to know that. Let me see. It won't let me copy that. I don't know why. So the body attempts to equalize the partial pressure, which in results, oxygen diffuses across the membrane into the blood. Oxygen and carbon dioxide both diffuse until the partial pressures in the air and oxygen are air and blood are equal, which is pretty cool. So to me, it's just like, wow, it just so much goes on so fast that we don't even have to think about. I mean, our bodies are like small computers that work on their own as long as we have the function of oxygen and blood that keeps everything going. So let me read that again. So make sure y'all grasp this real quick. So this is, as we're moving further, it makes a little bit more sense. Oxygen and carbon dioxide both diffuse until the partial pressure in the air and the blood are equal. That's just, it blows my mind how freaking cool that it just happens, that our body's just like, all right, we're cool, exhale, all right, we're full, you know, we got to get rid of the waste somehow. Now that carbon dioxide's got to move. So, all right, so the mechanism of ventilation can be illustrated by using a bell jar. So the inhalation and chest expansion is automatically, so the bell jar is on the right. Exhalation and chest contraction, anatomic left, and the bell's right. So the air is going out. As you can see, there's no pressure here. So this is just exhaling. On the inhalation creates the negative pressure where the lungs are going to contract. They're going to get bigger. Inspiration delivers oxygen to the alveoli. Not all inspired air reaches the alveoli for gas exchange. Tidal volume means the depth of breathing, and tidal volume for an average adult is 500 milliliters. Dead space is the portion of the inspired air that falls to reach the alveoli. All right, so the dead space is the portion of inspired air that fails to reach the alveoli. So we all have this dead space area, and it's just oxygen just sits there that we don't need, and they get rid of it. So tidal volume, so 500 milliliters. Let's see, I'm trying to think what's equal to 500 milliliters. So it's like saying a 1 liter Coke bottle is average for the adult lung. I don't know how many exactly milliliters that is. I'm just using for its illustration in all of our heads. Then we can break it down like the little bitty Coke bottles that is like size for a pediatric. We can break it down further than there to an infant, anything like that. This is just visualization. It's how I'm a visual type of person. Exhalation. All right, so does not normally require muscular effort, and it is a passive process. The diaphragm and the intercostal muscles relax, which decreases the size of the thorax. The smaller thorax compresses air in the lungs into smaller space. The air pressure in the thorax is higher than the outside pressure, and then air is pushed out through the trachea. So upon exhalation, again, that's passive. So it's gonna create that, it wants to equal out the pressure. So the air's gotta go from inside, and then we're gonna rush in some more. So when we exhale, we're exhaling oxygen, carbon dioxide, and just unused oxygen that's coming from our dead space. Now, again, I'm sure there's a chart to measure and how much comes out, what goes in. And I don't know the name of that particular process, but I know there is one. So when we talk about ventilation, so regulation of ventilation involves a complex series of receptors and feedback loops that senses gas concentrations in the body fluids and sends message to the respiratory center in the brain to adjust the rate and depth of ventilation. The body's need for oxygen is constantly changing. Failure to meet this need may result in hypoxia, and condition which the tissues and cells of the body do not get enough oxygen. If not corrected, the patient may die quickly. And then the hypoxic drive. The hypoxic drive differs from the primary control of breathing into that it uses levels of oxygen to control breathing. And this typically is seen in patients with the end stage of COPD. Some believe that administering high levels of oxygen will increase the amount of oxygen dissolved in the plasma and negatively affect the body's drive to breathe. Y'all give me 2 seconds. I need to step off and get my glasses real quick. All right, sorry about that. Maybe I look a little bit smarter now. All right, so if we don't fix the issue when the body's recognizing that we're in the need to get more oxygen, and that's not fixed either by us, supplemental oxygen, we provide that as first responders, or we turn around and realize like, hey, look, our drive for oxygen is not meeting the need for our body. At some point in time, we as individuals going through that have to fix it, like the fight or flight mode, where it dumps that epinephrine in there and our hypoxia drive kicks in saying, whoa, we need some more oxygen. Something's going on and we need to breathe a lot more oxygen because we're using up all the energy that we have right now. We need some oxygen to support us and back down to the cellular level. Oh, let's see. So oxygenation. This is the process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. So this is required for internal respiration to take place. Oxygenation does not guarantee that the internal respiration is taking place. So ventilation without oxygenation can occur in places where oxygen levels in the breathing air have been depleted, such as in mines, confined space, or high altitudes. So again, when you go to any of those areas, so if like here, I'll give you an example. So when I went from Mississippi to Afghanistan, that's a 6,000 foot difference of change. I had a pretty hard time breathing for about the first 6 weeks. I would get winded really easy. I was running still. I gave that up. But I started having issues with breathing. I was like, I can't catch my breath a lot. And I was noticing that I would turn around and I was taking a lot more oxygen treatments. And then even when I came home, I was like, man, I'm breathing so much better. It's because of the altitude change, but I adapted myself to where I trained with an altitude mask. So my body was trying to get used to it all the time. Now it's the same thing. You climbing high mountains, you can go deeps in caves. They supply with the supplemental oxygen with the mask. It can be a full face mask, or they can just wear just a cover. Can, like the pilots, they clip onto their mask. They have to provide that because the body's realizing it's very thin oxygen at these levels. Or down in caves where there's not much oxygen movement in there. So you may just be breathing in stale, stagnant air that doesn't have a lot of exchange of oxygen, carbon dioxide, or all the other nasty oxygen or stuff that's gases that's in the air from being in caves. So that's why we're talking about we need to work on our ventilation and oxygenation. We need to know more about oxygenation where we're delivering clean oxygen to the alveoli levels. And that's where, supplemental oxygen, SCBAs for firefighters, they wear clean air. And the same thing is you can have buddy bottles when you go diving and stuff like that. You take those oxygen with you. So respiration is the actual exchange of oxygen and carbon dioxide in the alveoli and in tissues of the body. So cells take up energy and nutrients through a series of chemical processes known as metabolism or cellular respiration. Each cell combines nutrients and oxygen, producing energy and waste products. It's mainly clear water and carbon dioxide. So that's where we're maybe getting rid of some waste in the urinary system. It's just waste of the body, so it's got to go through the filters through the kidneys and all that, and can get passed out. So here's let's see, talks about good oxygen coming in. Where's my point? So oxygen's coming in, CO2's coming out from the capillaries into the alveoli. You can see where the good oxygen is represented here in red, and it's trying to push out the CO2s out, and it's going to turn around and exchange through the nasal passage or the oral passage. So it's got to get down to the little levels in this box, which is broken into right here and the top portion, just to kind of let you see the small at the cellular level where it's exchanging, and it's going in and out of the blood level. So the waste is going out. It's going to turn around, go back through the heart, and get filtered out through the rest of the body, like on a normal basis when we're trying to get rid of waste. Let's see. So now we're going to talk about internal respiration. So it's the exchange of oxygen and carbon dioxide between the systemic circulatory system and the cells of the body. Oxygen passes from blood to the capillaries to tissue cells. So as you can see in the picture, that's where clean oxygen's passing in, and then the carbon dioxide waste is coming out. All cells need a constant supply of oxygen to survive. When there is an adequate oxygen, cells convert glucose into energy through the aerobic metabolism. Wow, without adequate oxygenation, anaerobic metabolism takes place, which cannot meet the metabolic demands of the cell. So we need those energies, we need the oxygen, and that's the reason why it's like, hey, look, something's wrong. It's got to click into overdrive and draw from the body to get this process to speed up. That's the reason why we need to be addicted to oxygenation. We need to be addicted to air. We need this passage to normally help. When it's not there, the body can activate this process, is what we talk about here, is the aerobic metabolism. Wow. So when we talk about that process, it's just that it's an overdrive part for our body. That's a backup drive. Normal, we breathe in, we breathe out, like on this picture here. Clean oxygen comes in, carbon dioxide goes out. But when we don't have that process happening, that's when we're all like, oh, something's got to happen. Well, that's that overdrive kicks in for us. The pathophysiology of respiration. So let's break it down. So the factors of the nervous system. So the chemoreceptors, they monitor the levels of oxygen, carbon dioxide, hydrogen ions, and the pH of the cerebrospinal fluid, and provide feedback to the respiratory system. Like, wow, like that is just so freaking crazy that our body's just like, it's just keeping its own chemical lab up on a regular basis, and we just live in it. We're trying to function and trying to understand how it works, and it's like, I'm sorry, what did you say, Chris? Because I mean, it blows my mind to sit here and think about it when you're just sitting there resting, you're like, I don't have to do nothing, and my body's just making it breathe on its own. So when the serum carbon dioxide or hydrogen ions levels increase, the chemoreceptors stimulate the medulla to increase the respiratory rate. So the body's telling the medulla oblongata, hey, you need to speed up, you need to increase that respiratory rate. The stimulation from the pons affects the rate and depth of the respirations. So it can tell us, do we need to breathe in deep, or we need to, it affects those two processes. It tells us what we need to do. And that's just our brain just saying, hey, look, we need to off this. We need to bring more oxygen in, or your pH is a little high in your body. And you're like, wow, that just blows your mind again. Ventilation perfusion ratio and mismatch. So again, I hope we aren't confused, but it does get confusing. The ventilation and perfusion must be directed to the same place at the same time. Failure to match the ventilation and perfusion is the cause of most abnormalities of oxygen and carbon dioxide exchange. So I'm gonna break that down. I'm gonna try to get it broken down for you here. All right. So when ventilation is compromised, but perfusion continues, blood passes over some alveolar membranes without exchanging any gas at all. The result is a lack of oxygen diffusion across the membrane and into the blood circulation. Carbon dioxide is not able to diffuse across the membrane and into the lungs, and therefore it recirculates within the bloodstream. So we don't need that process to happen. We need clean blood. We need clean oxygen to pass through us, and we don't need to recycle any part of this carbon dioxide. When perfusion across the alveolar membrane is disrupted, optimal exchange of gases is prevented. So just because let's say we pass out and we don't take a deep breath for a couple of minutes, but we are doing some agonal respirations. So agonal respirations is not efficient enough to support life, but our heart is still pumping. So that's where it's recirculating that CO2, because there's no exchange of gas at all for that CO2 to be pushed out. So a lot of times that's when we're like, we may just have to give a rescue breath to where we can stimulate the body to be like, and start breathing again. I will tell you, the first time you give somebody a rescue breath and they do that to you, you're going to about pee on yourself, just letting you know. Because it's happened before. I wasn't ready for it. Factors that are affecting the pulmonary ventilation. So we have infections, allergic reactions, and unresponsiveness. It talks about tongue obstruction, but remember, you're not going to swallow your tongue. It's just gonna, it could be due to the reaction where the tongue has swollen and it's blocking the airway. It's just you're not going to swallow it. So some of your intrinsic factors are going to be obviously trauma. So if you've had trauma to the face, to where it has either removed this portion of the body and now your trachea and all that's exposed, could be to where you've had a lot of facial fractures, facial damage, and that process is not there again. So there's several factors that rely into that, but just understanding that trauma is one of those extrinsic ones that can take place. Infections, they're going to be more of like a pulmonary infection, pneumonia, are going to be some of your biggest ones. We've seen COVID here lately affect the respiratory tract. We've seen a lot more reports here in the past few days talking about lingering positives and lingering effects from COVID. Those are something that's not going to be known for the next couple of years. And then it's going to be another medical diagnosis that we as an EMS have to learn to deal with and how to treat these patients. So some of your factors that it's affecting respirations, we have external factors such as atmospheric pressure and partial pressure of the oxygen in the ambient environment. So some of your internal factors, such as conditions that reduce the surface area for gas exchange and consistently decrease the body's oxygen supply, leading to inadequate tissue perfusion. So in that, we're talking about pneumonia, pulmonary edema, which I'll say COPD and emphysema. All those are going to affect how much oxygen is brought into the body. If anybody knows anybody that has COPD and it's bad enough, you notice a lot of those patients with COPD don't ever sleep flat. They always either sleep at an angle, they sleep in a chair. Your more severe ones start to sleep into a chair, like a recliner that's more comfortable to them. That when they start to lay down, they feel like they're drowning, and that's because of it's just obstruction. Emphysema is the same thing. You talk about the fluid on the lungs. That is something that they take medications to help dry up with. Some of your circulatory compromise, obstruction of the blood flow to individual cells and tissues can relate to trauma emergencies. So a simple tension pneumothorax, an open pneumothorax, hemothorax, and a hemopneumothorax. Y'all tell me what those are. Somebody to pick up a simple pneumothorax, a tension pneumothorax. There should be 5 that y'all can tell me real fast. Y'all can tell me what those are.
I think the simple tension pneumothorax is like a sore throat or strep throat or something like that.
Okay. So let me give you the definition.
Oh, sorry, go ahead.
No, go ahead, Christina. You're fine. Keep going.
A pneumothorax, isn't that where your lung is? Like, I don't know how to say that. Like a rib or something punctures your lung, collapses.
So y'all look real quick in the chat what Rodney typed in there. So that's going to help us remember right there. Remember how we broke down the meanings of the words? So hemo is blood, pneumo is air, and then you have talked about collapse. So real quick, so a spontaneous pneumothorax is a sudden onset of collapse lung without any apparent cause, such as a traumatic injury to the chest, are known as a lung disease. So pneumothorax is air inside the cavity of the lung. So remember, we have our lung cavity, and when the diaphragm contracts, it exhales, you know what I'm saying? So there's air along the walls, and here where it's not supposed to be. Air is supposed to be inside the lungs on each side. Then when you have blood, you have the Hemo Pneumo, or it can just be a hemothorax. It's all in the pleural space of the lung cavity. Now, granted, I can do a chest decompression, and I can also do one on the side to where I can potentially relieve the potentially the pneumo and hemo. But if it gets further down into the lungs, it's harder for me to do that. You have to have a tube get stuck up in there and drain all that stuff out. Has a negative pressure and kind of sucks all the blood out. But on a normal basis, y'all are correct. So the hemo, pneumo, simple intention, those are something that we do face. They can be from traumatics. They can have people that have regularly have lung collapses, and they'll tell you, they're like, oh, I'm having trouble. This is my lung collapse. And you're like, repeat what you just said. They're so used to that due to an infection, or they've had it for so long in their life that they know that it is what it is. And it's just, you got to take me to the hospital to get it fixed. You can give them supplemental oxygen to assist with what's going on, but it's not going to fix it. That's something we're just not gonna be like, all right, we're going to pump you up to about 10 and we're going to inflate that lung back up. It's just not going to happen. So knowing what those words are. So this one right here, so the open pneumothorax also refers to as a sucking chest wound. Real quick, I'll tell you, fix those with a 3-sided occlusive dressing. Just remember it as you want to go up and over because you want it to be able to burp to where when it comes out, it'll burp air out, but it's not going to allow it for suck back in. Recently, kind of give you an idea, out on the platform, we had a guy that was shot with 20,000 PSI of water. When it entered the chest, when he come to me, he had blood all over the place. He was walking, talking, he was super pale, went through everything. I thought he had a open sucking chest wound on an open pneumothorax. I was able to auscultate it, which I was listening for it, but I could tell that there was some differences in the right and left. So I treated it just like the sucking chest wound, got it situated, got his breathing under control. I never once put him on supplemental oxygen because he was breathing at 20 times a minute and he was satting at 98%. Well, just because he's at 98 doesn't mean that I can make it 100 and he's better. No, that's still really good. But not knowing what those are is something that we need to fix. And the best way we can do it is you can put your hand over it initially and cover that wound. If I just stick it up there, now I've just created a cover that opens the sucking chest wound and I fixed the problem for the meantime. Now I can have whomever give me whatever and fix it. I personally like the chest seals that the round ones that you can kind of cut and place wherever you want. We have the square ones, but they work really good. I've even used down to a sandwich bag before. I've cut it on both sides, flopped it open, cut it on thirds. I've laid it straight down on top of them. They work great. It's nothing that's just, you're just trying to create a cover. You can use saran wrap. You use anything like that, that's going to create a cover over that wound. So you can buy the commercial grade or you can kind of make your own. Let's see, some other causes of circulatory compromise will be blood loss, anemia, hypovolemic shock, or vasodilation. So any type of shock is going to be crucial because we don't really, without being able to fix it, we're looking at it blind, like, I don't know what's going on, but something bad's going on. Massive blood loss, we know that that's going to create the person to go into shock because we only have so much blood in our bodies. We could off about 2 pints of blood and we're going to be a little lethargic, but we'll be okay. I will be able to off a little bit more than, let's say, my 17-year-old is because I have we have the same amount of blood, but I have more vascular, more perfusion and more blood throughout the cavities and all that. So he's going to notice a little bit more going into shock than I would initially. And at the same time as when children go into shock, they're going to crash fast. So when you see something in a child, you need to fix that super fast, because it's going to be over quick, and then you're going to be fighting from behind, and that sucks. I can promise you, it sucks fighting from the backside. All right. So patient assessments. All right. So I'll tell you what, let's take 10 minutes here. I don't want to start this because we're going to get into it. I won't be able to finish in 10 minutes our slides before we take a break. So let's take 10 minutes and I will see y'all back at, let's say 7:02. All right. Does anybody have any questions so far? All right. Well, I'll see y'all back in 10 minutes. Thank y'all. All right. Anybody have any questions so far? I know it's a whole lot, so trust me, I feel y'all. All right, so diving off into patient assessment. Oh, hang on, my slides just off on my phone. All right, so what we're going to do is we're going to wear a mask and all right. So wear a mask, protective eyewear that includes eye shields whenever airway management is including suctioning or aerosol generated procedures. So anytime that we are starting to put airway adjunct down, anytime that we start suctioning, anytime we start to do CPR, what we need to do is start to think about eyewear. Now, something a little bit better than like my glasses currently is something that we should try to do. I don't want to say safety glasses, but kind of in that manner, something that kind of covers the side of your eyes here. Because if there's any type of vomit that flies, it keeps it out of our face. So the AGPs include CPR, neb treatments, endotracheal intubations, and continuous positive airways. So we should have that even if we're going to turn around and put somebody on the just a regular non-rebreather. So recognizing adequate breathing. So what is something that when we look at them, we know that breaths are a normal adult respiration should be anything between 12 to 20 breaths a minute. We talk about regular patterns of inhalation and exhalations. When we listen to their lungs, bilateral, clear, and equal lung sounds are very important. We have regular, equal chest rise and fall, so it's not like one-sided, and then it's back, and it's off. We have adequate depth, which is the tidal volume. All those are important when we start looking to recognize what the adequate breathing is. Recognizing what is abnormal. So anything that is fewer than 12 breaths a minute or more than 20, it's in the presence of short of breath or dyspnea. Remember that dyspnea is one or two words, and then they're having trouble breathing. So that is dyspnea. So it's an irregular rhythm. They're not on a continuous inhalation, exhalation. You don't have that regular rhythm. Can somebody else see the slides, or is that just, well, how about that? Is that better? My bad. I forgot to click a button. Thank you, Devin. I appreciate you saying that. My bad. All right, so diminished and absent noisy auscultation breath sound. So if I can hear them breathing and it sounds like they have a seal sound, that's not normal breath sounds. And then reduced flow of expired air through the nose and the mouth, where they're just breathing. You're like, you good, bro? I'd be like, hey, bro, you good? So any type of that is a abnormal breath sounds. It's anything that's it's still adequate for life, but it's not normal to where at some point in time they may go into respiratory distress or into respiratory failure. What's going on? So unequal and inadequate chest expansion results in the reduced tidal volume. We have increased effort of breathing, uses of an accessory muscles, and we talked about. Then your stomach is your accessory muscles. If the stomach goes out and the breath chest goes in, stomach goes in, chest goes out, that's the use of accessory muscles. Shallow depth is reduced of the tidal volume. The skin that is pale, cyanotic blue, it's cool or moist or clammy. It's just like when you touch them, you're like, you sticky. Like little kids that come in from playing so hard outside, and you're like, yo, it's good to see you too. Skin pulling from around the ribs or above the clavicles during inspiration. So we talk about that's retractions when it's trying to pull in just because like they're trying to create that deep breath and it's just not there. You start to look at patients right around to the neck areas. You start to see the ribs. They're just trying to gain all of that because there's not a good respiratory drive that's going on. So we talk about here on this slide. So a patient may appear to be breathing after the heart stops. These occasional gas breaths are called agonal gas. Cheyne-Stokes respirations are often seen in patients with stroke or head injuries, and breathing with increasing rate and depth of breathing with increasing rate and depth of respirations followed by apnea. So here, as you can see, this is it is a regular, irregular pattern, but we talk about Cheyne-Stokes. So it's rough, 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 and then it's real. It's so that it's within a minute volume. So that's your Cheyne-Stokes. And I don't know if y'all remember me telling y'all, go to YouTube and look those different types of breath sounds up. It's very hard for me to just show you those without you listening to that. You can listen to them on a generator, like a respiratory rhythm generator. But it's not as, I tell you, it's not as good as when you go and listen to them like on YouTube and you can pick that sound up and you're like, oh, I can definitely tell a difference. So if you haven't done that yet, please go and look those up. That will be very beneficial. All right. So we talk about ataxic respirations, have an irregular or unidentifiable pattern, and that may follow serious head injuries. Let's see. So patients experiencing a metabolic or toxic disorder may display other abnormal respiratory patterns such as Kussmaul respirations. So Kussmaul respirations are deep, rapid respirations commonly seen in patients with a metabolic acidosis. So patients in inadequate breathing needs to be treated immediately. We need to do something to fix that respiratory problem. That drive is being off-centered by the brain's normal response and say, okay, kick in, breathe, breathe, breathe. Well, the Kussmaul respirations it's fixable, but we have to do that on the front end. We need to know that we need to supply that supplemental oxygen as fast as we can. All right. So emergency medical care, what are we going to do for this? We're going to do airway management, we're going to do supplemental oxygen, and we're going to do ventilatory support. So we have to do all that. So do we need to put something down their nose or their mouth, which is as an adjunct? Supplemental oxygen, are we going to provide them with high flow oxygen? And then we're going to give them ventilatory support. Like it's long term. We're going to make sure that we continue to give them oxygen. Even though the patient may be ventilating properly, the actual exchange of oxygen carbon dioxide at the tissue level may be compromised, which is by several factors. So again, we talk about the high altitudes. We talk about maybe their exposure to poisonous gas, like in the home. Including of carbon dioxide, enclosed spaces where there's no fresh oxygen coming in and out, and a patient's level of consciousness and skin color are excellent indicators of respiration. So if they don't look pale and cyanotic, you don't start to see the blueness around the lips, their fingertips don't look to be a little bluish. If they have those signs of the bluish around here and they look a little pale, the fingers are a little blue, that is signs of inadequate respiration. So we know we have to do something to fix that. We need to supply some sort of oxygen to help them breathe better or remove them from an area. When assessing a patient's, consider proper ventilation, which may be assessed by the pulse ox. Remember, the pulse ox goes on the finger. Oxygen saturation, or the SpO2, is a measure of the percentage of hemoglobin molecules that are bound in the arterial blood. I'm going to say that again. Oxygen saturation, or SpO2, is a measure of the percentage of hemoglobin molecules that are bound in arterial blood. All right. So in conditions, SpO2 should be higher than 94% with breathing room air. In conditions such as a stroke, heart attack, oxygen is always supplied. in the when the SpO2 is less than 94. Pulse oximeters can take as long as 60 seconds to reflect changes in the patient's oxygen saturation status. The patient can develop a respiratory insufficiency well before the pulse ox has read that. So even though we're using that pulse ox and we put it on, I, Chris Wally, like to put it on, read it, let it read for a couple of minutes, and I mean like 2 or 3. I provide them oxygen. I let it read for 2 or 3 more minutes before I read it again. So there's going to be a span about 7 minutes between there from the initial to the time I look at it again that tells me if anything of my ventilatory status, have I improved it? Have I helped them get any better? So if I continuously to watch it and I'm like, okay, I don't see it moving. I don't see it moving. I put it on, leave it and forget it, and then I come back to it. Because it's going to take that time, and it can take longer than 60 seconds for somebody that's like, let's say they're old and frail. We're not going to see that instant change because y'all just said, I told you it takes up to 60 seconds. So that being the case, we may not be able to see that change for a hot minute. So put it on, leave it and forget it, and come back to it. Entitled CO2 is the measurement of a maximal concentration of CO2 at the end of an exhale breath. So a low carbon dioxide level could initiate hyperventilation, decreased CO2 returning to the lungs, or reduced CO2 production at the cellular level. And then a high CO2 may indicate that the patient's retaining CO2 secondary to ventilation inadequacy and apnea. So those are 2 different things that you can see from low CO2 to high CO2 that we have to recognize. And the reason why in low CO2 that you're going to see the hyperventilation. Y'all stand by 1 second. Sorry about that. Still having to do the fatherly duties here. All right. So if we know that they're low CO2, they're going to be hyperventilating because their body is trying to exhale that CO2. They're trying to get it over, trying to get it out, trying to push it away. That's the reason why it needs to go there. So somebody with high level CO2, you're going to see that apnea, that is just going to be frail. It's going to have, they're just not going to be breathing normally. So entitled CO2 is measured using capnography and a capnometer. So capnography refers to the use of a device that provides a digital numeric reading of end-tidal CO2 level. Capnography provides both a numeric reading and a graph form from breath to breath. So good ones look like shark tails. And they go up and down. I don't think we showed those in here. I think I just didn't know about bringing them. No, ma'am. Put that back. Sorry, y'all. I'm having to be. No, ma'am. And the normal range is anywhere between 35 to 45 millimeters of mercury. And it can be used in a spontaneously breathing patients with adequate airway using a special nasal cannula. So, so it can be used. So instead, if I put them on a normal cannula, it's got the little 2 prongs that goes there. I'm not going to get a capnography off of that. So I have to exchange them. It looks just like the same 2 probes, but it's got a little flap that comes down. It's like a little kind of a round flap that goes over. So it's a little cap that goes over it. We can turn around and put those on and try to see if they were able to pick up CO2. If it doesn't pick up CO2, sometimes you have to give it a minute, let it cycle through the whole tube process, and it can also breathe oxygen in when we do it that way. So all that is done through a process, still delivering oxygen as a little tube that goes into our monitor. We screw it in, and it reads our CO2 for our capnography, which is really cool. It helps us out tremendous. Lets us know what the good levels of CO2 and the bad levels are, if we need to increase their oxygen saturation or not. So we talk about opening the airway. So now this is when we're going to start trying to figure out, now we have to do something either by nasal or orally, or we're going to supply a supplemental oxygen, but for some reason they're not breathing adequately enough. So rapidly assess whether an unconscious patient's airway and pulse is breathing is adequate. Position the patient supine. Unconscious patients should be moved to as a unit because of the potential for a spinal injury. You should be able to see that on your 11-2 in your book about having to move them. In an unconscious patient, the most common airway obstruction is the patient's tongue, which falls back into the throat when the muscles of the throat and tongue relax. So go back to our CPR days. So the head tilt chin lift maneuver will open the airway in most patients. For patients who have not sustained or not suspected of having a spinal trauma, the simple maneuver is sometimes all is needed to open the patient's airway. Just again, that little head tilt chin lift maneuver, pull the jaw down, and they're able to start breathing. Sometimes they are, sometimes that is an enough autonomic response for them to be able to do that. And it's not, if not, we have to provide rescue breaths with a bag valve mask, a BVM, and we can go on from there. So with the patient supine, position yourself beside the patient's head. Place the heel of one hand on the patient's forehead to apply backward pressure. I'm hoping to goodness that all of y'all have taken CPR. I'm pretty sure that y'all have at one point taken CPR and you are certified. So I'm not going to read over the proper doing the head tilt chin lift. The jaw thrust is just as important if we suspect any type of spinal trauma. Opening the mouth may look something similar to this. If we have to use our jaws to push down on the lower mandible, and then we can open the jaw just by, when our thumbs are up here, just applying downward pressure. And that's how we're going to do that. Now, let's talk about suctioning. So these are all pretty cool. So we only, let's see here. You must keep the airway clear to ventilate the patient properly. If the patient's airway is not clear, you will force fluids and secretion into the lungs, resulting in aspiration. So if you hear gurgling, the patient needs to be suctioned. Now, so the portable, hand operated and fixed. So here's your portable. This is your fixed location, and this is your hand operated. Your hand will wear out. Now, these do fill up pretty fast, but just remember, you have to change them out too. Same thing with the rest of these, but these hold a lot. I've only changed one out in my career, and it was a traumatic situation, and I was suctioning out blood to keep the airway open so I could put a tube down there. All right, so a portable suction unit must provide enough vacuum pressure and flow to allow you to suction the mouth and nose effectively. Hand-operated suction units with disposable chambers are reliable, they are effective, and relatively inexpensive. A fixed suction unit generally generate airflow for more than 40 liters a minute and a vacuum of more than 300 millimeters of mercury when the tubing is clamped. So these can go up very high in your units, and these will only go up to a certain point before they're just like, hey, I'm out. My battery's struggling. I can't go all I have. Now the ones C right here also have the wall plug-in. So it's not uncommon for you to turn around and plug these in at somebody's house. If you're having trouble, like let's say you're not getting enough power or you're just run out of power because it's taken so long, then that may be one of those to where you just have to plug it in at somebody's house. Now on figure A, that may be something that's kept in your jump bag to where it's not expected to be a situation where you need the portable suction and you just don't bring it in. But I will tell you, on any type of, they're having a cardiac, if you get called for a cardiac symptom, take your suction with you. Just make it a habit. Yes, it's always gonna be on the way. Yes, you're gonna be like, oh crap, I forgot the suction. But the day that you don't bring it is the day that you're gonna need it. And that's gonna fall back on you, and it's gonna suck because it's gonna make you look bad because you just didn't get it done. So a portable or fixed unit should be fitted with the following. So you should have a wide bore, thick walled, non-kinking tubing. So no matter what you do, that tubing's not going to kink. You have a plastic rigid suction tip, and that's called a tonsil tip. It's either a yanker tip or a duo canto catheter. There's two types. So the best kind of catheter so the duo catheter is what they're calling for the best types for infants and children. The large diameter plastic tips are rigid and do not collapse. So the non-rigid plastic catheters called French or whistle tips catheters, they're used to suction the nose and liquid secretions from the back of the mouth, and in situations where you cannot use just a rigid catheter. So you may have to stick it down into the nose to where it sucks down into the back of the airway on a regular. They do the same thing if you've ever had a gastrocclusion, to where they suck poop out your nose. It's kind of the same thing. They put I think it's an 11 French all the way down into your stomach, and it suctions it up through your nose. It sucks. So anyway, so this is a non-breakable disposable collection bottle. So the water supply for rinsing for the tips, so you're gonna have to have some type of like normal saline and a bottle to be able to suction tip out, because there do sometimes get some chunks and you ain't getting rid of it. Before inserting any catheter, measure for the proper size. Use the same technique as when you're measuring for an oropharyngeal airway. So remember that when we go over how you measure, you're going to do the same thing for the suction, so you know exactly how far you can or can't push it down. So there are some techniques for suctioning. Make sure that you inspect all of your suction equipment prior to the start of shift. And there's certain ways that you want to check it. So you want to turn the unit on, check the unit properly for a symbol, make sure all those parts are there and they're all connected. So you want to turn on the suction to test to ensure that the vacuum's there, and it suctions the pressure of more than 300 millimeters of mercury. Select the attachment and appropriate suction to the tubing. Now, this is where it gets important. This is where I want y'all to start remembering here. Never suction the mouth or nose for more than 15 seconds at one time for an adult patient, and 10 seconds for children and 5 seconds for infants. So every time that you introduce the suction catheter into the mouth, you count 1 Mississippi, 2 Mississippi, 3 Mississippi, until 5, 10, or 15. And that way you pull it out, you stop, you ventilate them. Never suction any more than those 3 noted times. The suctioning can result in hypoxia because you're sucking the air out. You're pulling it all out. You're creating that negative pressure and it's pulling it straight out. Repeat suctioning only after the patient has been adequately ventilated and reoxygenated. Do not touch the back of the airway with the suction catheter. This can activate a gag reflex. You don't want that. You don't want it because you're going to end up wearing and vomit. I promise you. Sometimes a patient may have secretions or vomited that can be suctioned easily and quickly. And some units cannot remove objects such as teeth, foreign bodies, and food. In these cases, it's just not going to suck it out. It may get stuck and pull it out. So you have to remove the catheter from the patient's mouth, roll the patient on the side, and clear the mouth carefully with a gloved finger. Again, I don't like putting my digits in somebody's mouth. What I would rather do is I would take that suction catheter and stick it in the inside with it not suctioning and flake it out with that. It is a rigid, it's not going to collapse, it's not going to fold over in there, and just rake it out that way. I'm not putting my finger in somebody's mouth unless it's an infant that ain't got no teeth. I'm just not doing it. That is something that I want to keep these. So you can do that too. If a patient who requires assisted ventilations produce a frothy secretions, oh, sorry, I got sidetracked there. If a patient who requires assisted ventilation produces a frothy secretions, as quickly as you can, suction them out. Suction the airway for 15 seconds and less than if an infant or a child. And ventilate for 2 minutes. Continue this alternating pattern of suction, ventilation, and secretions once they've been cleared. So you may be ventilating them, holding it down, doing a bag valve mask, and you open their airway and you realize, oh crap, I got to suction out. So you count 1 Mississippi, 2 Mississippi for 15 seconds, set it to the side, start ventilating again. If you dislodge something that you're like, woo, 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 and the suction will not remove it, again, we can log roll them, like we just said, use that tip, drink it out, good to go. So that's something, one of those that we just use that icy hot. So remember, we don't want to use it any longer than that, because it's going to create an issue to we're not ventilating them properly. So go back to your 30 to 2 when we're doing our CPR. Suction's the same way. We're going to make time to do suction and clear the airway if we need to. All right, so now let's talk about basic airway adjuncts. So this is where we're going to talk about oropharyngeals and nasopharyngeals. So an airway adjunct prevents obstructions in the upper airway by the tongue and allows the passage of air and oxygen through the lungs. Oropharyngeal airways. So that keeps the tongue from blocked in the upper. I hope to goodness that we put a picture of these in here. No. So an oropharyngeal, it's a device that kind of makes in a broken form like this. And they're broke down to different sizes. I will make a note. Let me make a note to go in there and add. Because I want to add some pictures of this in there. So I also, I'm going to try to show y'all the best that I can, a picture of these devices. So these are all different colors for reasons, as you can see, they go all the way down to infant sizes, which would be this small little yellow, and they go up to like horse sizes. I'm just kidding, we're not sticking these in horses, but they're pretty large. So they are to be, you have to measure them. And I'm gonna bring this one up too, because I know it's coming. So the nasos. So you have to measure them. And I'm gonna tell you, I know that's broken down in here. So some of the indications that we're going to use these. So we talk about unresponsive patients without a gag reflex, which means they're breathing or they're apneic, okay? Apneic patients being well ventilated with a bag valve mask. Some of the contraindications. This includes a conscious patient, so we're not gonna put this on somebody that's conscious. It's just not gonna work. Any patient, conscious or unconscious, who has an intact gag reflex. And you know instantly some people, you go to stick and you're like, ah, and they will do that unconscious. You'll see them, you'll have that throat come up. They'll be like, what? Don't do it. Don't do it, y'all. I'm gonna tell you, it's not worth it. An oral airway that is too large could push the tongue back into the pharynx, blocking the airway. So that's why we want to make sure we get the right size for the right patient. An oral airway is that is too small could block the airway directly in any foreign body obstruction. To insert the oral airway properly, look on your book at 11.4. If you encounter any difficulty inserting the oral airway, an alternative method may be used, inserting it at a 90-degree rotation. I don't know what your books show, because I don't have a book, but I know it's telling me to tell y'all to look on 11.4 and 11.5 on how to do those. Let me scroll through and see if there's any.
On 11.4, it just shows somebody shaving, somebody on step 1, step 2, opening the patient's mouth with the cross finger technique, holding the airway upside down with your other hand. Step 3, rotate the airway 180 degrees, insert the airway until the flange rests on the patient's lip and teeth. In this position, the airway will hold the tongue forward. And then you said 11.5, right?
Yes.
11.5 is inserting the oral airway with a 90-degree rotation. Step 1, depress the tongue so that it remains forward. Step 2, insert the oral airway sideways from the corner of the mouth until the flange reaches the teeth. And then step 3, rotate the oral airway 90 degrees. Remove the bite stick as you exert gentle backward pressure on the oral airway until it rests securely in place against the lips and teeth.
Okay, so I have never ever used a tongue depressor, but so the way that you measure a oral
Wait, can I ask
pharyngeal
a
is
question right quick before you say that?
yeah, please do.
So the tongue depressor and the bite stick, that's the same thing, right?
Correct. Well, so no, so there is, so the tongue depressor basically is I'm pushing the tongue down as I'm inserting the oral airway. So the bite stick is what we want to wedge between the teeth. So if I'm going to put it in the center, which is where you want your oral airway, the
Right.
bite stick is it's normally about yay long, and they're all the ones that I've seen throughout years are pretty, they're always blue, but you wedge that between the teeth. So if they
But
start
does
to
that get in
have
the way
any
of
type
like the airway tools and stuff like that though?
no, it's not going to.
Even if, okay.
No, so
Yeah.
you're going to lay it flat like this. You're not going to lay it on its side.
Right,
You're going
right.
to try to lay
Even,
it flat.
but even in laying it flat, if you got like, I don't know. In my mind, if you
It's
got
okay.
one item laying there flat, then you're sticking another item above it, like.
So you're going to put the oral pharyngeal in first, the bite sticks later on.
Oh, okay, got you. Okay,
Yes, sir.
never
All
mind.
right. So
Okay.
the way that we measure is we're going to go from the corner of the mouth to the tip of the ear. And maybe I see my beard's in the way, but so the oral pharynx is going to measure from the tip of the ear to the corner of the mouth. And then that's the size we go off of. You can grab a couple of them, be like, okay, no, okay, that one looks right. So when you go to stick it in, you're going to have it facing upward, and I'm going to stick it in this way. And when I meet resistance, I'm going to rotate it 90 degrees and let the front part of it's going to rest against my teeth, and it's going to have a little open hole in the center, and that's where you're going to put the bag valve mask over, and you're going to be able to push air straight through there. So that's the proper way to do it. A lot of people can also take them when they're straight down, and they'll lay them straight in like that way. There's neither way is wrong, but if you start to have any type of issues where you can't get it because maybe the tongue's starting to swell, you would turn it upside down and then push it in this way and rotate 90 degrees. So that's why we want you to know that you can go both ways. Sometime if you catch them early and you're like, oh, I need to hurry and put an oral airway in, and you put it in the right the first time, not gonna be a problem. But there's 2 different ways to do that. All right, so a nasopharyngeal. Let me pull this picture up. So these are, if they look similar to that. Now, if y'all see that one that looks like a horse too, yes, those are huge. We also have them down to infants. I've never used one on an infant. I've intubated an infant versus putting a nasopharyngeal down there. It's just what I prefer. But so the nasopharyngeal is the same way. But when you go to insert the nasopharyngeal, it's going to go through the nose. So hold on, before I go in here, I know it talks about this, but we want to put the nasopharyngeal on the right side, the patient's right side, because most of the time that nostril is bigger than any other ones. But you're also going to need to lube it up. You should have packets of KY jelly in your bags. I have also at the same time opened up a patient's mouth, swallowed the tube in their mouth, used their own saliva and slid it in. I have done a nasopharyngeal on myself before. It is not comfortable. It is not at all comfortable. It has to be done correctly. Placing the bevel towards the inside, because it looks just like it's beveled on the end. So one side's a little bit, so they're curved. So it's not perfectly round, it is beveled off. You're gonna put the bevel towards the internostril on this side, on the inside of your nose, and you're gonna rotate that down, and it'll start twisting on its own. If it doesn't, you can twist it as you're putting it in. I just still remember me I had to do that as a skill when I was in the Middle East, and it's either do it or go home. I got it done, but I sure as heck didn't like it. So those also are done. So here's some of your indications. You have a semi-conscious patient or unconscious with a intact gag reflex. Patients who otherwise will tolerate an oropharyngeal, will not tolerate, sorry. Some of your contraindications, you don't want to give it to anybody that has a head injury or blood in the nose. And the reason why is they've had studies in the past to where an oropharyngeal, if they've had the plate fracture on the bottom side of the mouth, I just went completely blank what the name of that was, but they have had to where the nasopharyngeal was shoved into the base of the brain. I've also seen to where paramedics go to nasally intubate a patient and has done the same thing. It's not something common that we look for, but we don't normally do a nasal intubation, but we can. So anytime you suspect any type of head trauma or you see blood coming from the nose, just don't do it. Or if there's any type of history of a fractured nasal bone, because you're like, if you look at them, you're like, bro, you've had your nose broke about 17 times. Just don't use an oropharyngeal on anybody of that situation. So we talk about the recovery position. That goes back to your CPR and first aid days. Any type that may help if they're unconscious or semi-conscious, it's going to help them breathe on their own. So we talk about supplemental oxygen. All right, so supplemental oxygen is anything that we provide as a caregiver when we provide the supplemental oxygen. Always give supplemental oxygen to patients who are hypoxic because there's not enough oxygen is being supplied to the tissues and the cells of the body. Some tissues and organs, such as the heart and the central nervous system, lungs, kidneys, and liver, need constant supply of oxygen to function. Never, ever, ever, ever withhold oxygen from any patient who might need it, especially if you're assisting with ventilations. It is cheap and easy to give somebody oxygen. Put them on the nasal cannula, 2 little things, probes in their nose, and just give it to them. Makes them feel better. Like, I can't breathe. If you quit talking, you can probably breathe better, but you know, that's you. I'm just going to do what you need me to do. It's easy. Just give it to them and just check it on your box when you give them a report. Be like, oxygen provided. Patient stays and made it feel better. You may have saved that person's life and their thoughts because they were having trouble breathing. But realistically, if they would just stop screaming and talking, they could breathe fine. So, but again, if somebody at all says, I'm having trouble breathing, I just need some oxygen. Okay, hang on. I can give you that. You ain't got to have no orders for that. So supplemental oxygen, so we talk about the oxygen cylinders. The oxygen that you will give patients is usually supplied as a compressed gas. It's in a green, it has a steel or aluminum cylinders. Just to let you know that you have to have a doctor's prescription to get oxygen. So most of your ambulance services have to have their med control doctor once a year fill out a prescription so they can order oxygen. It's pretty cool.
Hey, Chris.
Yes.
If you have a patient that's on 10 liters of oxygen, just a tidbit, make sure your main O2 is full before you drive like 3 hours away.
Yeah, if not, you're going to be going through a lot of oxygen cylinders and you may run out.
Or have some agencies to the next main hospital that's en route.
Yeah, and then you go like an idiot, be like, "Hey, I need some oxygen batteries. What y'all got?" I've in my career have had to pick up other patients off the side of the road because the ambulance provider that was transporting them ran out of oxygen. It's not something that's uncommon, but whenever you get hired on with whatever service you work with, you go through their orientation process and they have certain things that they teach you. And no matter if you have a company that pre-checks your truck to make sure everything's there, there's just certain things that you must make sure that are there. Like your suction works, you got batteries, your AEDs working, or your life pack, you got great batteries in there. Your radio's got charged batteries, your main O2 is full, your portable oxygen tanks are full. That's just some things that you as a provider need to make sure that happens, that you check those. All right, so here's where we start talking about, y'all gonna write down about these cylinders, all right? So check the month and the year that are stamped into these cylinders because they're hydro tested. And if they're out of their hydro test date, you cannot use them. They have to come off the shelf. It don't matter if you find it and you're on a 48-hour shift and your station's an hour away, doesn't matter. You cannot use those bottles. So an aluminum cylinders are tested every 5 years and a composite cylinders are tested every 3 years. So if it has a test date of I think it's 01/22, it won't have a line or a dash. That means it was just tested in January and it's good for 3 or 5 years, depending on if it's composite or aluminum. All right, so most often your D cylinders or a jumbo D are the cylinders that will be used as a portable tank. Now those, I can't, there's a picture out there of the different types of cylinders, but know that most of your cylinders that are on your EMS unit for portable cylinders are going to be the D or the jumbo D sizes. So the length and time that you can use the oxygen cylinders depends, it really depends on how much oxygen you're providing. If you're using a portable oxygen tank with a ventilator and you're ventilating a patient from, because maybe it's a cardiac arrest and your paramedic got the tube down and you're hooking them up to this portable oxygen tank inside the house, which is fine, you can do that. But you got to come outside because you're going to drain that, a ventilator is going to drain a portable O2 tank in about 12 minutes. So you better hope you're close to your truck. Now your main O2 tank will probably last you 45 minutes to an hour, but you got to think you don't want to be transporting that far with somebody on a ventilator and not having multiple backups. So those are some of the things you need to think about too. So liquid oxygen is becoming more commonly used as an alternative to compressed oxygen. That hasn't made it to Mississippi that I'm aware of. It is expensive too, but I know like Alabama has liquid oxygen on their tank. I mean, on their trucks and their ambulances. It's just something new that's out there that everybody's trying to figure out. Oh, this is the way to go. Or, this is the way to go. You can have different conversations on which one's better than the others, but to me, it doesn't matter. Whichever the doctors want, let's just do it. Give it to them. Next, some safety concerns about these tanks. Just remember, you got to be careful with them because if something happens, you drop the tank and it shears off the valve, it's going to shoot out just like a rocket. It's the same thing that you've seen like the Coke and Mentos. They're going to shoot out. It has a compressor. It has a compression of compressed oxygen that it wants out too. Make sure that the correct pressure regulator is firmly attached before you transport it. A puncture or hole in the tank can turn into a deadly missile, and it will. Cylinders, secure cylinders with mounting brackets. That is a National Department of Transportation requirement that they have to be secured. Oxygen cylinders that are used during transport should be positioned correctly and secured. A lot of your stretchers nowadays have oxygen tank compartments built onto your stretcher, and most of the time they're just held on by like some Velcro. Some of them I've seen have sleeves built into them. Most of the time you use those between the residence to the truck and then from the truck inside the facility. It's just as another aid, and you don't have to worry about grabbing it all the time because it's connected to your stretcher. Some companies don't use those anymore because it's a pretty expensive upgrade. So it's one of those that it's not a big deal that if you have it or not, but make sure you keep your oxygen cylinders on handy, that you're keeping them full and you check them. If depending on what other companies' regulations are, you may not, it's highly suggested not using them below anytime they get to 1,000 psi. That's time that needs to be replaced. Some agencies will let you use them up to 500 psi. So that's some of the things that you have to worry about too. Ma'am, my daughter's coming around being nosy. You want to say hi?
Hi.
So that's my little mini me. So on these cylinders, make sure you correct them and you know which ones that your pressures are. If you're using them on a call, make sure you know that you're like, oh yeah, I need to check that oxygen tank. We used it for a hot minute. A lot of times you can go through a whole shift and not use all the oxygen tank, but it depends on how high you're using it, how much oxygen you're flowing through, and what delivery device. So it's going to tell you, it's going to regulate your time. Oh, let's see. A pin index system for its so the pin systems are some ones that you're going to find for like your In your hospital facilities, you hook in like a ventilator. It's the same thing in your ambulance. There's green plugs that are set inside the wall. If you've been into the hospitals, they have the green, the yellow ones and stuff like that. So you can have compressed oxygen, you can have liquid oxygen. All those have certain types of pins, and those pins will only fit in the designated, and that's why they're colored. So the greens will go into the green plugins, the yellow will go into the yellow plugins. And like y'all know, in the emergency, if you go into a hospital, everything that's on emergency power is red. Ambulances really don't have emergency power because we work off just the battery. But those supplemental pinned systems only fit into the right pinned system that's in the ambulance, and they will also interoperate between a fixed facility and your ambulance. So if you're trying to hook up a ventilator, all you got to do is plug it's just a push pull, and you twist it and pull it to disconnect it. So that's what that one is. Pressure regulators are reduce the cylinder pressure to a useful therapeutic range for the patient, normally between 40 to 70 psi. After the pressure is reduced to a workable level, the final attachment for delivering the gas is one of the following. So you have a quick connect. It's a quick connect female fitting with a accepted and a quick connect male. They plug from a pressure hose to a ventilator or respirator. A flow meter that will permit the regulated release of a gas measured in liters per minute. And that's most of the time what you will use on your portable O2 is a flow meter. And those flow meters are whatever the ambulance says. These are the ones we recognize, and these are the only ones that we supply. It's just something that's just supply and demand. And those regulators have certain type of they call them nipples. They'll fit over and fit on the oxygen bottle just right, and you crank it down, and that's what lets it know it can let the pressure out. And then you're able to reduce the high pressure to a working pressure on your O2 tank by your flow meter. So it is permanently attached to the pressure regulator on emergency medical equipment. The pressure compensator flow meter incorporates a float ball with a tapered calibrated tube. So these are the ones that you can also see in medical facilities that attach into the wall. They can regulate the pressure. So it's like the oxygen tree. Some ambulance services still have those that they can connect from one on the driver's side and one to the passenger side, depending upon how many patients they have. And they can still work off of the main O2 that's inside your ambulance too. So a burden gauge flow meter is a gauge that's calibrated to record the flow rate, and it can be used in any position. So some of those are only vertically, so it doesn't matter with the burden gauge, that they can be flat or point up and down, and they're still going to flow and give you the correct amount of pressure. We know some of the hazards. They are combusted. And they have oxygen toxicity. So when we talk about oxygen toxicity, we are not going to be around a patient long enough to create any type of oxygen toxicity. Now, not saying that we can potentially do cause that, but we aren't going to be providing that high of O2 for that long for a patient to have any issues. Now, if you're doing an inter-facility hospital transfer and you're going out of town for like the next 6 hours, and the doctor's like, hey, they're only allowed to have 3 liters a minute per nasal cannula. Okay, well, that's preventing maybe because they are a COPD patient, or they may be having a oxygen toxicity because they've some other medically related issues just causing them that they need to stay on the lower end. It's just something that we need to follow as we start to and learn, and when we start to do inter-facility transports and long haul trip transfers. I think the longest one I've ever done was from Jackson to, I think I went to Nashville, and it was one continuous trip. We spent the night, turned around, came back, but that was a hot drive, a long drive, and especially changing back and forth the ambulance in the front and the back. So combustion, so oxygen does not burn or explode. It does speed up the combustion process. So if some of your firemen, you remember your fire tetrahedron, that's where it comes from. Keep any possible source of fire away from the area while oxygen is in use. Make sure that the area is adequately ventilated, especially in industrial settings, and never leave oxygen cylinders standing up when unattended. Always lay them down. I always like to pick on this, and I mean it with no hard feelings, but firemen will always turn on that oxygen cylinder, turn it on, leave it standing up, and you're like, bruh, They're like, you can't do that. And just I always mess with them. I love my firemen around here, especially when I'm on the ambulance. There are some good folks. But it's just a habit that you do is you turn it on, you leave it up. You can lay those bottles on their side. It's okay. Once you hook the patient up, just lay it back down. What it does is it keeps from that tree being broken off and now having a missile on our premises. I don't want to bring no gun to a knife fight. And I don't want to bring a knife to just a fist fight. So lay that oxygen down so we don't have no missiles brought into us. All right, so oxygen toxicity. Not all patients require high flow O2, like we've already talked about. Excessive supplemental oxygen can have a detrimental effect on patients with certain diseases, as in COPD, cerebral vascular accidents, myocardial infractions. We talk about oxygen toxicity refers to the damage to the cellular tissue due to excessive oxygen levels in the blood. Increased cellular oxygen levels contribute to the production of oxygen-free radicals, which can lead to tissue damage and cellular death in some patients. The International Liaison Committee on Resuscitation Guidelines, published by the American Heart Association, that's a tongue twister right there, recognize there may be negative effects of oxygen toxicity and recommend that oxygen be administered to patients experiencing signs of myocardial infarctions. When they have signs of heart failure, are short of breath, and they have have a room air oxygen saturation less than 94. We give them oxygen, period. Patients experiencing signs of shock should be placed on oxygen. Hypoxemia is much worse than oxygen toxicity. When in doubt, or if unable to measure the saturation reliability, supplemental oxygen should be administered. Do not withhold it. When pulse oximetry is available, tailor oxygen therapy to the patient's needs and administer the minimum amount of oxygen necessary to maintain oxygen saturation at a minimum of 94%. So if the patient's having a hard time breathing and you put it on and they're at like 94, don't withhold it, but put them on that nasal cannula at like 2 or 3 liters per minute. And here's my spiel. So if you go to somebody's home, and this may be within your family, and they're on a home oxygen delivery device, it's the machine in the corner that's always running, has the humidified, is blowing air into the little containment of water, and they're on it, but they're on a 50-foot cord of nasal cannula. And you go to them and you put them on a 4-foot cord at the same liters per minute, and they're like, I can't breathe. I just can't breathe. It's not enough. So let's talk about friction loss and how well you're not getting the 4 liters because it's not pumping through 50 feet. And what if that hose is kinked, because those hoses are made to be moved and twisted and turned and all that. So I always try to do a little bit of education when I go into those type of homes or those settings, nursing homes, to where let's put you on a pulse ox, and this tells me, and I point at it, how much oxygen you have in your body. Now I put them on my oxygen, and then I wait a few minutes and show them again, be like, look, your blood, your oxygen in your fingers and your cellular level is increasing on mine. You're having more oxygen in your body. And they're like, oh, it's just the difference. And sometimes you may have to up the home machine to get them to that level because they're on 2 liters or a liter per minute on that. And you're like, I don't even feel it coming out the nasal cannula. So you're like, I don't even know what to do, people. So those are the things that we have to deal with. And a lot of it is just education that we have to tell these people, educate them a little bit and give them a little bit of information. And it's not that we're trying to be ugly. It's trying to help them out and feel better. All right, so now we're going to talk about delivery devices. So we have our non-rebreathers, we have our bag mask, and then we have a nasal cannula. Those are the 3 that we're mainly going to use: a non-rebreather mask, a bag mask device, and a nasal cannula. So non-rebreathers, as you can see on your screen, combines a mask with a reservoir bag system. So the oxygen fills a reservoir bag attached to the mask by a one-way valve. So right here at the very tip is a one-way valve. When you plug this up to your oxygen delivery system and you go 10 liters or more. It can be, so these can only deliver at 10 liters up to 15 liters. You want to put your gloved finger over this one-way valve and let this bag fill up before you place it on the patient. Because if not, there's not enough oxygen that's going to build up into this reservoir that's going to be able to fill this up when a patient's been severe respiratory compromised. So fill that reservoir up first. Oh, let's see. Exhale gas escapes through the flapper valve on the portions of the cheek, which is right here. You can see there's a flapper valve. There should be one on this side. It's probably fallen off. So make sure the reservoir bag, I told you that, and I told you that it flows at anywhere from 10 to 15 liters per minute. If the bag does collapse, increase the flow rate. So if you start them at 10 liters and they're starting to suck that bag in, up them up, go up to 12. When the oxygen therapy is discontinued, remove the mask from the patient's face. That can potentially cause harm. And it's available in adult, pediatric, and infant size. Most of the time, your children aren't going to tolerate that. So you're going to have a parent do a blow-by device or leave it sitting right here in their face to where they're getting that oxygen. And it's not really your infants, and they're just going to fight that. I find it more effectively if you do the blow-by device, just let the parents or yourself hold it in their face, or especially if you have that infant in their car seat, I like to wedge it right in between where their shoulder straps come down into the chest to where that oxygen is flowing in their face. Now, again, I can't use just a regular pulse ox on an infant. I have to use the one with the tape. So I can either tape it to their little toes, or I can tape it to their forehead to get a good oxygen saturation level. So nasal cannulas. So delivery oxygen through two small tube-like prongs that fit into the patient's nostrils, and it can provide 24% to 44% inspired oxygen when the flow meter is set at 1 to 6 liters. For the patient comfort, flow rates above 6 liters are not recommended, because you will start to see the nasals like, you'll start seeing them flap. It is funny. You're going to do it once in your life and forget that's set that high, but I'm just going to let you know, you're like, oh, I'm sorry about that. I apologize. I actually twisted it too high. And then you're going to giggle to yourself. That's not common. You want to go anywhere between 2 to 4 liters on a nasal cannula. So I will tell you these two. Do not forget when you get to the hospital to unhook this end, okay? This is what you're going to have hooked to your truck. It's going to wrap around. It's going to come back over, go over their nose, and come around here. Because when you forget it and you go to pull them out of the ambulance, you're going to see them go, I can't do it. And it's going to stretch their head back. Eventually, it will pull off and go off. But it's not what's supposed to happen. You're supposed to disconnect it and hook it up to your portable O2 or some other potential ways to get that oxygen delivery as you're going inside the facility. So that being said, make sure if you have any oxygen systems that are hooked up in your truck that you transfer them to your portable oxygen before you depart your truck at the medical facility. You will do it once, and then you'll remember, be like, oh man, Chris told me to do that. I promise. So we're going to use the nasal cannula on patients with mild hypoxemia. As a patient who breathes through their mouth in a nasal obstruction and has nasal obstruction will not benefit. When you anticipate a long transport time, consider using humidification, which means we're just going to put it through sterile water and let it fluctuate through there. Next. So we talk about partial rebreathing mask. So here's a partial rebreathing mask, and you can set it to whatever. So the colors, you can set to what liters per minute you want. And this is the saturation. My cat is just deciding to be a part of class tonight. So sorry. No, ma'am, go on. So the Venturi mask, not a lot of these masks. We don't use these down in the South. I'm not a whole lot familiar with these, but sorry, y'all. Go. You come get the cat. Never mind. She's down. All right. So let's see. The Venturi mask has a number of attachments and can carry a percent of oxygen while a constant flow is maintained. Medium flow devices can deliver anywhere between 24 to 40%, depending on the manufacturer. So you change these little devices out down here. You can see the size of the hole is also dependent on the percentage of oxygen comes through. And that's how you can work on the Venturi mask. Again, I don't have a lot of experience with this, so I can't really give you a lot of information about those. I've never even really seen one. I just know how I know how they're supposed to function. How's that? So you have your tracheostomy mask. So if you'll notice, these look very similar to a non-rebreather, but these are built to go over your trachs where patients have the tube in their mouth. It's made to go strictly over that. So these masks do not have a reservoir at the bottom, but these are exhalation valves. So when they do exhale through the trach, the stoma, that it releases through the flapper valves right here. Oxygen goes through the bottom. You can use a non-rebreather at the last resort, but as you can see, this is a non-rebreather right here because you can see that it's going down to where it has the bag. But they do have masks that are particularly made for stomas and tracheostomies to help function that way. That's just another type of device that we have to recommend. So these may not be available in emergency settings, which is in case you should improvise by placing a face mask over the stoma, like we just talked about, using that non-rebreather. Ooh, I'm sorry. I've gone over the hour. I tell you what, guys, let's take 10 minutes and I will see y'all back at 8:12. How about that? All right, I'll see y'all in just a minute and enjoy your 10 minutes. All right, so good information. We got about 30-ish sides left, so you don't have to be here all night long, but maybe 8:40-ish, we should be done. All right, so let's see here. Forgot even where I left off. All right, so some signs and symptoms, we talked about this a while ago, is inadequate ventilations. We know that it's just the abnormal respirations. They just look like they're in stress. You may have ultramental status. You may look and notice that their minute volume is off a little bit. And then again, we talked about accessory muscles. Those are just some simple signs that we know that, hey, look, we need to provide some, just some regular oxygen and try to see if we can help them out. What can I do least invasive that can get the biggest outcome? That's what I want to look for. Why is it not going? So to assist a patient with ventilation using a bag mask device. So it is kind of one of those devices that you're going to be placing, it goes over the mouth and the nose. You're going to want to explain this process to them. Hey, I understand that you're having trouble breathing. I'm going to put this device over your nose and your mouth, and I'm going to help you breathe. I want you to breathe as normal as you can. Then you're going to place the mouth and the mask over their mouth and nose. You're going to squeeze the bag each time to the patient breathe. They breathe. When you see them exhale, you want to squeeze in when they inhale. You want to try to maintain the same rate that patient does. After initiating the 5 to 10 breaths, slowly adjust your rate to deliver over the appropriate tidal volume. Adjust the rate and tidal volume to maintain adequate minute flow. And this is just supplying with artificial ventilation. So we're going to take this device and we're also going to hook it up to our portable O2, our main O2 in our ambulance, and work on this. So artificial ventilation is once the patient is not breathing, you're going to begin artificial ventilation immediately. So you can use a mouth to mask, a 1 or 2 person bag valve mask. So those are again, if you decide to do mouth to mask, I'm not telling you that you were wrong. I'm not telling you to do that because my personal opinion is I don't want to be that close to somebody that may vomit for something. Y'all, excuse me for 1 second. I'm about to sneeze everywhere. All right, sorry about that. So when we go to these procedures, just know when you start to do the mouth to mask that is something that is potentially going to be there. So your normal ventilations are versus positive pressure. So artificial ventilations are necessarily to sustain life, but they are not the same as a normal breathing. In normal breathing, the diaphragm contracts and the negative pressure is generated in the chest cavity, which we've talked about that, and we know that it sucks in the air into the chest. So positive pressure ventilation is generated by a device that forces air into the chest cavity. So I am forcefully compressing this air into the chest cavity, and I'm creating that positive pressure that I'm trying to hopefully get in to circulate the entire respiratory tract. With positive pressure ventilation, you will notice an increased interthoracic pressure, and that causes compression of the vena cava, and it reduces the blood return to the heart, which reduces the amount of blood pumped by the heart. So more volume is required to have the same effects as the normal breathing, which pushes the airway walls out of their normal anatomic shape. Air is forced into the stomach, causing gastric distension that could result in the vomit or aspiration. That is not good, I promise you. So if you so let's say you put that oral device in, and you're like, why is their tummy getting so big? And you start to push on their stomach and it's very rigid. Well, something's not right. You have bypassed, and there has been times that paramedics have done that. When you intubate somebody, you going into the gastric area, you went too far down instead of going up into the airway. So what happens is you're going to get the inflation of the gastric to where you're now going to have gastric distension. And it's got to come out one way or the other. It's got to go through the rectum, or it's going to come out the top area. So be careful for that. The EMT must regulate the rate and volume of artificial ventilations to help prevent the drop in the cardiac output. So knowing that we want to keep this, we have to be careful, because if we force too much air in there too, it's going to bypass the lungs and go into the gastric, to the stomach. Again, so we want to make sure that ratio is good. So ventilation's rate are: adult is 1 breath every 6 seconds. A child is 1 breath every 2 to 3 seconds. And an infant is also 1 breath every 2 to 3 seconds. This is informed with our AHA guidelines on doing CPR. So mouth to mouth and mouth to mask ventilations, a barrier device is routinely used in mouth to mouth. A mask and oxygen inlet provides oxygen during mouth to mask. This fat guy's not gonna do it, I'm sorry. Unless I know you and you are either my child or my wife, it's not gonna be doing mouth to mouth. So here is our bag valve mask, or you may see it a BVM. They're calling it a bag mask device. So the bag mask device provides less tidal volume than mouth to mouth ventilation, but delivers a much higher concentration of oxygen with a flow rate of 15 liters a minute and an adequate mouth to face mask to face seal. So when you use this device that's on your screen, you're going to be flowing the oxygen into the reservoir bag at 15 liters a minute. It does have a disposable self-inflation mask. So the mask, when it comes out the bag, this is automatically inflated. You don't have to worry about increasing that. This reservoir bag automatically inflates, so you don't have to try to find the one-way valve to kind of shut that off. So you do have a inline air filter, which is right into here in this neck, that keeps things from coming back into this. So if they vomit and you have it there, it's not going to pull back up. An oxygen reservoir that allows the delivery of high concentration oxygen. We've already talked about that. A one-way no jam inlet valve that provides an oxygen flow rate at a maximum of 15 liters a minute with a standard of 15 to 22 millimeters of mercury fitting for face mask and endotracheal. So this piece right here, this mouth to mask, this mask to face device comes off. So then I can take this little hole that's right here, and I can fit that over the trach. I can fit that over the ET tube that we intubate them with. They are all interchangeable. That is a standard across the board. So it doesn't matter if I come up with Wally's mouth to mask bag, it has to follow those standard procedures and be that size, the 15 to 22 millimeters. It is a transparent face mask because we want to see if there's anything that fills that area up, or if they're trying to vomit any area, to where we can suction them or turn them on their side. The ability to perform under extreme environmental conditions, the volume of air delivered is based on the observing chest rise and fall. So I want to squeeze the bag when they would normally be taking an inhalation. And I don't want to squeeze it when they're exhaling, because we're fighting against each other, and I'm going to feel resistance on that bag. When I go to squeeze, if they're exhaling, it's like, I mean, I can squeeze it, but you know something's not right. Once you get on that normal pattern of inhalations, you're going to be squeeze, squeeze, squeeze. And remember, how many breaths per second are there? Let's go back to here. Oh, it doesn't show y'all. So it's 1 breath every 6 seconds is what I was aiming for. So remember, that's what we're going to shoot for, 1 every 6 seconds. So gastric distension, we talked about that. I'm not even going to go into, because we've already talked about that one. So passive ventilation. So sometimes passive ventilation is called passive oxygenation or apneic oxygenation. Air movement into and out of the chest cavity occurs passively as a result of compressing the chest, CPR. When the chest is compressed, air is forced out of the thorax. As the chest recoils following compression, a negative pressure is created within the chest, which resorts into a vacuum. So it's like they're naturally going to try to breathe when they're unconscious. It's just a natural reflex. So air is sucked into the chest cavity, similar to what occurs when the muscle contraction, they're in active inhalation. So just because we're doing CPR and we push down and come up, we're creating that negative pressure inside the lungs. Passive ventilation can be exhaled by inserting an oropharyngeal airway into the providing supplemental oxygen. So if we want to, when we're bagging them, we'll put that airway, that oral adjunct in. We're going to bag them. We're going to leave that in place when we're doing CPR. So when we do that, we're creating a better passage for passive ventilation to be negatively sucked into the air, to the airway system. So an ATV, which is an automatic transport ventilator, which is the same thing that we can put people in the hospital on when they get put on a ventilator. We carry those on the ambulances also. So an ATV is a ventilation device attached to a control box that allows variables of ventilation to be set. You won't do that, so I'm just going to skip it. I promise you. So CPAP, CPAP is used in the medical field, also with being CPAP as in sleep apnea. All right. So continuous positive airway pressure is a non-invasive ventilatory support for patients experiencing respiratory distress. Many people diagnosed with obstructive sleep apnea wear a CPAP until a unit at night and maintain their airways while they sleep. CPAP is a pre-hospital environment, CPAP in the pre-hospital environment has proven to be excellent adjunct in treatment of respiratory distress associated with COPD, acute pulmonary and acute bronchospasms. CPAP is becoming widely used in the EMT level. So I have used CPAP multiple times on patients. When you look at them, you're just like, I got to forcefully get air into them. Now, if they go to open their mouth, it's going to create a until they close their mouth. The air is going to come in straight. It's just going to circle around, circle around. I use the CPAP at night. I think when I was quit breathing like 60 to 75 times an hour. My father-in-law used one and he was way higher than me, but I can notice my sleep difference is way better with the CPAP versus if I mistakenly forget it one night. I take this thing to the deer camp. That's how bad it is. It's just a different type of sleep. So you're starting to see these CPAP devices being commonly used more and more into the EMS level. And even when you put somebody on CPAP, you're going to need to let the receiving facility know the advised patient is on CPAP, and I have noticed changes because there is a respiratory system that's an issue there. They may have too much fluid in the lungs, which is creating them to have the drowning effect. So what we're doing is we're pushing air into it, or trying to push that fluid out of the alveoli, and we're trying to oxygenate it again. It's a very, if somebody's never had that, you must explain to them what's supposed to happen, because they just need to keep their mouth shut and breathe normally, and the air will be forced into their airway system. So if you've never had that on, you probably need to try it at least once in your career, so you can explain that to somebody, that how it's about to make you feel. Now, I've worn mine so much now, I've learned to be able to talk with mine, and you can sounds just like now. When I first started wearing it, it was like, I couldn't talk. It took me a while to figure things out. So CPAP increases the pressure in the lungs, which opens the collapsed alveoli and pushes oxygen across the alveolar membrane. So it forces fluid back and interosseous fluid back into the pulmonary circulation. So we're trying to just get rid of that fluid. We want to push it out in the interstitial space. We just want it to go. We don't want that fluid sticking around. It needs to get out of there. So that CPAP is what's availability that's making it being pushed out into the respiratory tract again. Let's see, we're almost 20 slides out, so maybe I lied. I was a little bit further than that. So CPAP is a therapy delivered to a face to mask that's held. That's with a strap that holds the system on, because there's so much pressure it will blow off. That's why you have to do a head strap around the head that holds it in place, and you have to adjust it. You have to adjust it by 4 different little pieces that's on the EMS unit. Most of the ones you see are full face that covers the mouth and the nose, goes around the chin. Most after I don't use that. I use just a nasal cup, one of my home one. But different people have different things. Like there's all different types of settings. But in the EMS world, it's going to be 15 liters a minute, high flow O2, and it's going to be a mouth to mask, nasal. It's going to look just like the bag valve mask. It's going to sit over them, and you're going to have a head net system that keeps it in place and keeps it from going anywhere once you get that good seal. So here's some indications of why we want to use CPAP. So the patient is alert and able to follow commands. The patient displays obvious signs of moderate to severe respiratory distress, and it's from conditions such known as edema, obstructive pulmonary disease, COPD. Respiratory distress occurs after a submersible incident. So if somebody's been pushed underwater and they've been like a drowning, the patient is breathing rapidly, such that it affects overall minute volume, and the pulse oximetry reading is less than 90. I can say CPAP specifically helped my mother when she was being transported to the hospital before her passing. A good friend of mine came and transported her, got her on the CPAP, and you could instantly see a change in her overall demeanor. She was able to breathe. It wasn't such a hard work for her. But unfortunately, that was the last time that she was at our home, and she stayed into the home hospice. So matter of fact, it's a sad time, but 3 years tomorrow will be the passing of my mom. So CPAP worked great for her. We are very pleased and we were happy. She had it on for a couple of hours. Even I want to say she may have had it on for a couple of days while she was in the facility. But they're great when they're trying to get that fluid off of them so they can breathe. It does. It's an amazing thing that these devices work very, very well. So some contraindications why we don't want to use CPAP. The patient is in respiratory arrest or has agonal respirations. If the patient is not breathing on their own, or they're unable to speak, or they're hyperventilating, those are some of the reasons why we just don't want to use this on them. A patient cannot protect his or her own airway, and the patient is hypotensive. So if we know what hypo means they have low blood pressure, that's one of the reasons why we also don't want to use CPAP. So if they're not able to maintain their own airway on a normal basis, we don't want to use CPAP because we could create some other issues that may end up just contemplating their airway problem, their airway tract, and their respiratory system. Signs and symptoms of pneumothorax or a chest trauma. Patient cannot sit upright. The patient is in cardiogenic shock, and the patient cannot tolerate the mask. So a lot of that, they can't tolerate the mask is they're already in a respiratory distress problem, and now I'm trying to fit this mask over their face. I haven't really explained the process to them sometimes. I know that sometimes I get caught up in the minute, and I forget to explain to these patients on what I'm doing, how I'm doing it, and the reason why. And then I go to put this on them, and they're just like, okay, breathe. And they don't want it on, which is completely fine. But if you're able to allow them to breathe for a couple of seconds with the CPAP device on, they're going to love it and they're going to want to stick it out. So the application of putting on CPAP, some components of the CPAP unit, you have your generator, which is it's in the wall already. You have the mask. You have your circuit containing the tubing. You have the bacteria filter, a one-way valve. The CPAP generator creates resistance through the respiratory cycle. This resistance creates a back pressure into the airway that pushes open the smaller airway structures, such as bronchioles and alveoli, as the patient exhales. The amount of pressure can be determined by adjusting the valve within the CPAP system or a separate valve that can be attached. A pressure of 7.0 to 10.0 of oxygen is generally an acceptable therapeutic range. So right here is our numbers, and it has a little device. I think I've seen them there on the bottom. I've seen some on the sides that you start at like a 6 and you work your way up. And when the patient starts to get better, like you're not instantly changing. You want to change it from a 6 to a 7, wait a couple of seconds, see how it does. If you notice any changes or not, you just need to adjust it more. Most CPAP units are powered by oxygen, so it is important to have a full cylinder of oxygen. That's like we were talking about earlier, how we want to make sure that our oxygen tanks are full, because this device is going to drain it pretty fast too, because it's a constant the entire time. So you're going to drain, and it's going to be at 15 liters. You're lucky if you get 20, maybe 30, 25 minutes out of it. It's been a while since I've been on the truck to do that. So I promise you, it's been a while. So they're going to drain pretty fast. You used to know the times. So some complications you're going to find is some patients may find CPAP claustrophobic and resist the application of the mask. You want to coach these patients through the process and try to tell them, please breathe in, breathe out. Due to the high volume of pressure that's generated by the CPAP, you do have a risk of a pneumothorax. But again, we're not going to be with them for that amount of time, and we're just trying to get them opened up, enough airway into them that we can drive lights and sirens to the hospital. High pressure in the chest can lower the patient's blood pressure. That is something you need to keep in mind. So when you're doing your assessment, you get your baseline, you get, when you put them, you put it on right before, you take another set of vitals right before you put it on there, and then you do it a 5 to 10 minutes afterwards. So you can see your range if there's any change in your blood pressure. If the patient shows signs of deterioration, remove the CPAP and begin positive pressure ventilation using a BVM. And you want to attach to a high flow oxygen. So again, we're still going to be using it, but now if the patient can't tolerate it, we're going to take that off. We're going to put a bag valve mask on, and we're going to breathe for them. And it's going to be hooked up to the 15 liters a minute. It's just a complete different device, but we're still trying to deliver oxygen through a passive way. So here's some special considerations. We want to talk about stomas and tracheostomy tubes. Patients who have a laryngeotomy have a permanent tracheostoma, which is an opening in the neck that connects to the trachea, and that's directed into the skin, and that's known as a tracheostomy. And they do look like that. Most of the time they have some type of covering over them. You can see sometimes people they put their fingers over it and they can talk, and then they can breathe and they have to cover it to talk. That's kind of mostly how the ones that you've seen now. A lot of people wear like bandanas around their neck because people are like, what's that? Like, people just aren't used to seeing that. And people these days are just rude, so they don't know what to say. If the patient has a tracheostomy tube, ventilate through the tube by a bag valve mask. And a standard 15 to 22 millimeter adapter to the bag valve mask will fit into the stoma. Use 100% oxygen attached directly to the bag valve mask. You do your best to try to hold your composure, and you're like, oh, I know it can go in there. Whoop, and you fit it. There's most of the time there's a ring on the inside of the stoma that they can take in and out to clean. Like on this picture, most of the time there's a little inner ring on the inside of here that makes it fit to a certain size. And that's the reason why that they tell you that the 15 to 22 millimeter is the adapter that fits into that, because that's the size that they make it to be. If the patient has a stoma but no tubes in place, use an infant or a child mask with a bag valve mask to make the seal. So you're going to want to take that infant mask, you're going to hold over the stoma, and you're still going to ventilate. You're going to sit here and bag through that stoma, and you're going to have to apply pressure over that mask to where you're holding it down on top of that stoma and you're still ventilating it. All right. Release the seal of the patient's mouth and nose for exhalation. This allows the air to exhale through the upper airway. You can try to suction the stoma and the mouth with a French soft. So you have to stick the little French tip down into the stoma. Most of the time, these patients can do it themselves because they've done it for so long. So it'll be like, hey, you want to do it? Because I've seen some of them stick it so far and they're like, I can't do that. I'm gonna let you do it, and you can chill. You can make yourself stall gagging. So if you have any type of foreign body obstruction, this will result into death if it's not immediately fixed, as we know that because it's obstructing the airway. In a child, it can occur while eating, most of the time playing with small toys, crawling on the floor, coins, anything that these infants and children they find, they go straight to their mouth. They're just learning, they don't know, but most of the time it is caused by some small object, like quarters, dimes, nickel, well, not really a dime, but quarters and nickels. Those are your most common causes of airway obstructions in children, or little balls or some little toys that they just go straight to their mouths with. By far the most common airway obstruction is an unconscious patient is the tongue, but it relaxes and falls to the back of the throat. Causing an airway obstructions that do not involve foreign bodies, you have swelling from an infection or acute allergic reaction. I actually saw one not too long, I think I told you, where the lady got bit by a black widow on her tongue, and it was like this, it was huge. It was just like, and I was like, what is that in her mouth? I didn't know it was her tongue until I read the article. So trauma obviously can cause damage from the injuries also. Think about that. If there's type of swelling, are they allergic to something? Maybe is it like a bee sting and it started affecting their tongue swelling? An allergy of, let's say, peanuts, that's also going to be one of those issues that we face. A mild airway obstruction, patients can still exchange air, but will have a various degrees of respiratory distress. Great care must be taken to prevent a mild airway obstruction from becoming a severe. Hey, y'all, hang on one second. Charlie. All right, so the patient may have a noisy breathing and may be coughing. With good air exchange, the patient can cough forcefully and allows this, that you may be able to hear the wheezing, maybe able to cough it up. As long as the patient can breathe, cough forcefully, or talk to you, you should not interfere with the patient's efforts to expel the foreign object on his or her own. Continuously reassess the patient. So if they're able to maintain their own airway, they're able to talk, maybe it's a little whisper, but he can tell. Don't do anything besides just provide any kind of immediate care that they need. If you need to, just give them the oxygen mask and let them take a few breaths, and then they're like, and they can cough it up on their own. Until they go unconscious, we don't want to mess with it. We want to allow it to be on their own, or the ability that we can. Poor air exchange, the patient has a weak, ineffective cough and may increase difficulty breathing, a stridor, or cyanosis. Cyanosis means they're pale, and you may have to treat it immediately if there's a severe airway obstruction. So now we got to step in. We may have to use our McGill forceps, which our McGill forceps are like long scissors. They're about yay long, kind of have a curve to them. And you can use that sometimes. If you can see the airway obstruction, you can stick it in there, clamp it, and pull it out. That's a little further down the road, but again, be careful with inserting your fingers into a patient's airway. Severe air obstructions, patient cannot breathe or talk. And here's old Fred. Oh, there's old Fred right there that can't breathe or talk or anything like that. So that's the universal sign for distress, that Fred's struggling. He needs some assistance there. And now it's our turn to act. That may be what your bystanders tell you. That's what they saw him doing. And that's how they knew that he was choking. There is little to no airway movement. We know that when we get there, that we start to have these issues. We may have to jump in and start doing airway assessment as soon as we get there. Your ABCs, we may not get past A's for a hot minute. Rodney says, can cyanosis be a kind of discoloration, or will it specifically be like, no, it can be. It can be more of a cyanosis is the paleness. Their face is super pale. You'll notice you want the blueness in the lips and the fingers may be a little late into the cyanosis, but you're going to be like, he's a little white. He's pale. Like what's wrong with that? When you talk to them, you'll notice that their overall demeanor is not there. That's a very good question, though, Rodney. Let's see here. So talking about dental appliances, anytime that you happen to know that there's dental implants and that they can be removed, we need to remove those from their mouth. I don't know much about dental any time of dental appliances, how to pop it. I don't know. But if we know that they are able to be removed, we need to remove that on the beginning, because that helps us in the long run, so we don't have any type of airway obstructions. Maybe the teeth start to fall out of their implant, and that's now starts to be able to cause an airway obstruction. They talk in here about a crown, a bridge, or dentures. Maybe it's a piece of a brace. We can't remove their braces, but being mindful if you notice that you start to see these, that maybe they are missing something, be very cautious and just ask you, be like, hey, bro, is his front tooth always like been missing, or is that like, no, he's there. I just don't know what happened to it. And that may be, start looking around the area underneath the patient, on the patient, or just take into consideration that he or she may have swallowed that. Any type of facial bleeding. So the face is very porous of veins. Men, when we shave, it bleeds and bleeds and bleeds. That's why I hate shaving. I just think it's for the birds. But if we can, any type of facial injury is going to bleed drastically, and it's going to take a while to stop it. We think we may have it under control, and then like, bam, it starts bleeding again. So be cautious of that. If it's something that you need to do a lot of suctioning on, you may have to suction a lot on facial injuries, mouth injuries, because they're so venous, and it's just copious amounts of bleeding will happen any type of facial injury. And same thing for facial traumas. So assisting with ALS procedures, when a critical patient needs an advanced airway or an intervention, the paramedic will perform these skills, but the EMT will play an essential role and to help getting these procedures, performing these BLS airways, and ventilatory maneuvers may help monitor the patient. So assisting the placement of an advanced airway. So endotracheal intubation, the first steps, we're going to pre-oxygenate the patient. It's the same thing we want to do. So when we pre-ventilate them, I want them to stay anywhere between 12 to 20 breaths a minute, but I'm going to probably increase it. So if they're normally breathing about 14 to 16, I'm going to probably up it to 18 or 20 on the high end sides. Personal protective equipment. Again, we know we need the eyes, the mask, the gowns, not really the gowns, but the eyes, the eye protection and the mask. Those are probably important. We always want to have suctions around. We want to make sure the suction's ready to work and that it's ready to go when we get ready to do these things, especially intubations. We want to look for the laryngoscope, make sure the blade's working, the lights on the hair is working. Those are certain things that you can do as a partner in making sure that all these are ready to go. Sometimes you want to make sure, so we talk about here's the mnemonic on the page. It says performing a procedure, be magic, perform bag mouth, prevent pre-ventilation. E is evaluate for airway difficulties. M, manipulate the patient, which means head tilt, chin lift, or jaw thrust. A is attempt first pass intubation. GI, use a superior glycotic airway if unable to intubate, which means like a King airway or a device like that. And C, confirm successful intubation. So successful, we have to have condensation in the tube. We have to have visual confirmation of passing the cords. Oh God, there's another one. And auscultation. So we have to hear both breath sounds. So those are three simple things that you can notice as a partner. If I'm intubating, those are some of the things that you can help us do. Or on the paramedic side is, because I'm going to be holding that tube and I want you to confirm it for me. And then once I get it, I'm going to get you to hold it and I'm going to secure it and then I'm going to confirm it. Now, does anybody have any questions for tonight at all for me? It was a lot. I didn't lie. It's going to get more and more and more. I promise you, it's going to get very in depth. I encourage all y'all to stop, ask questions, type them in the notes. I try my best to keep an eye on the notes down there as we're going over it. I will try my best to send slides. The reason why it's super hard is because it's so big. There's 121 slides, so I don't know if they'll go through the email channel, but I will try my best. All right.
Is the intubation process a hard process?
Say that one more time.
Is the intubation process a hard process?
The setup for intubation is hard. Doing it initially, and we do a lot of training on mannequins. So you get a lot of confirmation that way. And then when you get into the hospital settings and you start doing, live intubations, it's a skill that you can lose. I'll say it that way. I'm very particular about intubation, so I like to do a lot of remedial training. So here at my local firehouse that's around me, they have a intubation mannequin, and I like to practice because I don't get to do that a lot. And I'm okay with not doing that skill a lot, but it is the setup. It's one of those that you need to just take a deep breath, relax, calm down. It's like starting an IV. After a while, they just become normal things like breathing. But again, the process before you get to that point is what's nerve-wracking, and visually knowing that, hey, I'm supposed to stick this tube down somebody's throat and that's the only way that they're going to be living. So I can't mess up. That's the hard part too. All right, folks, I am going to hit enter, and the next slide over. That is your class code for tonight. Golf Tango November 88 GTN 88. That is your class code for the night. Don't forget your class test opens at 10 p.m. tonight. It closes at midnight on Sunday. I am going to, before anybody signs out, you need to listen to this. Going forward, I will move your module exams. They will close Monday night at midnight. So going forward, so mod 2 exam, you will have an extra day only on the module 2 exam. Your regular chapter test will close 3 days at midnight before that. So Rodney, I did a lot of work for the Department of State, and I was the medic that transported people across countries, and I was their medics. I did a lot of ambassador work in Afghanistan and a little bit of mobile work in Iraq. So chapter test will close Sunday night at midnight, and then your module exam, when it comes open, will close on that Monday night at midnight. Hope that makes sense. When you look at your test, all the dates and everything will be right. All right, folks, if y'all need anything else, please let me know. I'm gonna sit here quiet with my screen turned off and everything. If you need something, just message me and I will be glad to help you out. If not, y'all have a wonderful weekend and stay safe. See y'all back Tuesday night.
Are we still on for the class Saturday?
Don't know, baby. If y'all are going to a boot camp, then y'all need to continue to do what y'all set up with Rob. I have no idea about that.
Oh, so it's not mandatory, or is it mandatory?
Yes, they are mandatory. Your boot camps are mandatory.
Okay.
But I wasn't in that. I know that I saw some transactions going back and forth in the group chat. I haven't been part of the boot camps because there's really not any in my area, and I don't really travel 3.5 hours either direction for one. So if that's something y'all set up with Rob and that's in the group chat, please make sure you're there at those boot camps because they were very, very beneficial.
Okay.